For decades, the thoracic surgeon's instinct has been binary. If a tumor is anatomically resectable, you excise it to achieve a macroscopic complete resection. In 2026, clinical guidelines have pivoted. For malignant pleural mesothelioma, the decision to operate depends on a detailed biological assessment rather than surgical access. The update begins at diagnosis. Differentiating true MPM from benign reactive mesothelial hyperplasia now strictly requires immunohistochemistry profiling. Pathologists look for specific molecular absences. The loss of BAP1 and MTAP proteins on an IHC stain are the mandatory markers required to confirm a malignant diagnosis. This molecular confirmation acts as a hard stop. It halts any immediate surgical intervention until the tumor's underlying biology is fully mapped. Anatomical resectability does not dictate the treatment pathway. Cellular biology is the gatekeeper for managing MPM. This flowchart illustrates the 2025 ASCO diagnostic pathway for epithelioid MPM, moving from pleural effusion to IHC staining and nuclear grading. Here, tumors are classified as low-grade or high-grade based on their nuclear grade and mitotic count. The presence of necrosis within this grading system carries severe prognostic weight. Historically, patients with high-grade necrotic tumors experienced consistently poor outcomes following surgery. Once the tumor is graded, the protocol dictates evaluating the patient's genetics. The 2025 ASCO guidelines mandate universal germline testing for all newly diagnosed patients. The data reveals that between 12 and 14% of MPM patients carry pathogenic germline mutations, predominantly located in the BAP1 gene. This screening serves as a foundational requirement that directly informs frontline therapy decisions. This Kaplan-Meier curve shows 5-year data from the landmark CheckMate 743 trial. The dual immunotherapy curve separates cleanly above the chemotherapy curve. Dual immunotherapy achieved a 14% 5-year survival rate, while chemotherapy yielded just 6%. Looking at median overall survival, the immunotherapy arm reached 18.1 months, compared to 14.1 months for standard chemotherapy. The separation widens when isolating the non-epithelioid subgroup, sarcomatoid and biphasic tumors, historically resistant to chemotherapy. Here, the 5-year survival rate is 12% with immunotherapy, against a mere 1% with chemotherapy. This yields a hazard ratio of 0.48. For non-epithelioid patients receiving chemotherapy, long-term survival is effectively 0. Dual immunotherapy is the undisputed standard of care for non-epithelioid MPM. Other frontline approaches for these subtypes are now considered clinically inadequate. The data for patients with epithelioid disease presents a different scenario. In this subgroup, CheckMate 743 created a state of clinical equipoise. The survival benefit for epithelioid patients on dual immunotherapy was much more modest, resulting in a hazard ratio of 0.85. The IND.227 and Keynote 483 trials provided a distinct systemic solution for this specific epithelioid population. This protocol combines the immune checkpoint inhibitor pembrolizumab with standard platinum and pemetrexed chemotherapy. This bar chart visualizes the objective response rates across regimens. While chemotherapy alone and dual immunotherapy both sit at roughly 33%, the chemo-immunotherapy combination spikes to a 62% objective response rate, delivering a median overall survival of 17.3 months. Because of this high response rate, chemo-immunotherapy is the preferred intervention for patients with bulky epithelioid disease or those requiring neoadjuvant tumor shrinkage. While systemic therapies advanced, the MARS-2 trial rigorously tested the value of the traditional surgical mandate. In this trial, patients with resectable disease received 2 cycles of platinum pemetrexed. They were then randomized to receive either extended pleurectomy and decortication, followed by more chemotherapy, or chemotherapy alone. The MARS-2 forest plot reveals a 28% increased risk of early death for the surgical arm compared to chemotherapy alone. Translating to median overall survival, the chemotherapy group reached 24.8 months, while the surgery group fell to 21.4 months. The morbidity cost was severe. The surgical group suffered a 3.6-fold increase in serious adverse events. Based on these findings, extended surgical resection is now shown to actively harm resectable patients compared to systemic therapy alone. Since the MARS-2 data proves that surgery harms the average resectable patient, we must establish exactly who still qualifies for the operating room. The 2026 selective candidate filters out most patients. Biologically, they must have a strictly low-grade epithelial tumor. Anatomically, they must be clinical stage 1, with no N2 nodal involvement, no bulky disease, and an ECOG performance status of 0 or 1. Finally, the intervention must be a lung-sparing pleurectomy and decortication, abandoning extrapleural pneumonectomy entirely, and it must be performed exclusively at a high-volume mesothelioma excellence center. In current practice, surgical resection functions as an ultra-selective adjunct, reserved for a microscopic fraction of anatomically and biologically optimal candidates. This shift toward biological profiling has changed the prognosis for MPM. It is transitioning from a rapidly fatal condition to one with a viable 5-year survival tail. With long-term survivorship rates roughly doubling, oncologists must now factor in second-line salvage strategies for when frontline treatments eventually fail. For patients who progress on frontline chemotherapy, the RAMOS trial protocol offers a combination of ramucirumab and pembrolizumab. Alternatively, nivolumab, with or without ipilimumab, serves as an effective second-line strategy. These regimens carry specific clinical realities. Combining immune checkpoint inhibitors introduces a 30% risk of grade 3 or 4 immune-related adverse events. To manage this extended timeline, traditional RECIST criteria are being replaced by volumetric CT measurements and ctDNA analysis to catch early disease progression. Successful MPM management today requires shifting clinical focus away from acute surgical recovery and toward chronic immune toxicity management and precision longitudinal monitoring. This chart maps the incidence and relative survival of rare tumors. Mesothelioma sits squarely at the low end of both metrics, cementing its status as an exceptionally rare and deadly orphan disease. This graph illustrates the global trajectory of the disease. While incidence in the West is declining, we see a sharp rise in both asbestos use and subsequent mesothelioma cases across developing nations in Asia. As this global wave crests, adherence to the new biology-first guidelines will be the only way for international health systems to scale effective care. In multidisciplinary team meetings today, the critical decision is no longer, can we resect it? The question is, should we? For the vast majority of patients, especially those with non-epithelioid or high-grade disease, the data dictates that the answer to surgery is definitively no. Because systemic immunotherapy now drives patient survival, effective management requires prioritizing tumor biology over surgical anatomy.